Hello and welcome to this new podcast of the American Journal of Public Health. Today is a very special podcast because it is dedicated to LGBTQ month, and we thought that would be a terrific opportunity to have a conversation with two of the greatest experts on the topic, and in particular focusing on the health of transgender persons. So here are our guests. We have Admiral Rachel Levine. She's the Assistant Secretary for Health at the Department of Health and Human Service. Good afternoon, Dr. Levine.
Good afternoon. It's a pleasure to be here.
Well, it's a pleasure for us to have you. And we also have another guest from the Williams Institute at UCLA. This is Elana Redfield, and she's a JD lawyer, and she is the Federal Policy Director of that institute. Elana, very nice to have you.
I'm so glad to be here. Thank you so much for having me on.
All right. And of course, this podcast has been organized, prepared, and will be co-moderated with my great colleague, Vickie Mays, who is an associate editor of the journal and also a professor at UCLA. Vickie, welcome.
Thank you very much. And let me just start by saying I'm excited about this particular podcast because we've had great guests, and it's very timely in terms of thinking about the knowledge that they're going to share with the public. So I'm going to start off.
Please do.
Let me start by saying, we have to applaud HHS because in the last couple of years, we've really seen a lot of progress in terms of making visible health, mental health, as well as the data needs of the transgender population in the U.S. Now, some of the foundation for this work has been accomplished in states, and this is where I actually want to start. Dr. Levine, maybe you can start off by talking about what you saw as the needs of Pennsylvania and what you saw as wins and losses that were at the state level, and then the agenda that you saw for the federal level.
Well, thank you very much for that question. So yes, previously to this position, I was the Physician General and then the Secretary of Health of Pennsylvania under Governor Tom Wolf. And Governor Wolf was a strong ally for the LGBTQI plus community. And I was able to further those efforts for LGBTQI plus in general, but also transgender individuals, trans youth, in my roles in public health in Pennsylvania. You know, many of those issues are the same type of issues that we are addressing federally. Number one is health equity. Health equity is fundamental to everything that we're doing at the Department of Health and Human Services under Secretary Becerra, and of course under the leadership of President Biden and Vice President Harris. And so health equity for many communities, but also for our broader LGBTQI plus community and transgender individuals and their families in particular. One example would be in terms of mental health. We've seen significant mental health challenges among youth, particularly LGBTQI plus and vulnerable trans youth. And so we are working to safeguard these youth from the harms, for example, of conversion therapy. SAMHSA published a groundbreaking report last year documenting the harms of conversion therapy. We have enacted policies to protect youth in the foster care system and in the runaway and homeless youth system. For 988, the hotline, there is a specific sub-network where if you dial or text 3, you'll be directed to specifically trained counselors for LGBTQI plus individuals, particularly youth. And you mentioned data, and data we know is critical at public health at all levels. And we have adopted a very progressive and comprehensive SOGI data action plan, sexual orientation, gender identity data action plan. So we are really working in terms of policy and in terms of regulations and in terms of advocacy in support of the LGBTQI plus community, particularly, as I mentioned, vulnerable transgender youth, their families, and their medical providers.
I love the fact that you remember to say not just the individuals, but their families. Sometimes those are created families. Other times it is their, actual biologic family. And, it's the ways in which we think about the delivery of services, the data that we need. And so I really like the comprehensive way that it's a community, and we have to think about, the families as well, particularly for youth. Let me just ask this question because, data is critical. Now, in the past, what federal government has usually done, particularly for healthy people, is they said, we need big population-based data sets upon which to draw. And that's the only way we're going to set our targets. I wonder if, both of you, Elana, particularly because we know Williams really develops policies drawn from data, if you could talk about how the data is the same or different in terms of being able to meet the federal government's evidence-based policy direction now.
Thank you for the question. That's a great question. And it's exciting to be here with Admiral Levine as well, because HHS has been such a leader. To back up a bit, President Biden did issue a directive, Executive Order 14075, that asked agencies to look at all the ways that they collect data and examine whether sexual orientation and gender identity should be included. And a lot of agencies have taken that charge and moved forward, but HHS has pretty much been leading that charge. And just so you can see such a comprehensive way in which data collection is impacted. So I would definitely point out the incredible fact sheet that the HHS just put out this past week. There's great information there. But I'll say what we look at, Williams Institute, we are a research organization, and we don't advocate for anything except better research. But one thing that we've been advocating for throughout the existence of the Institute is high quality SOGI data from large population surveys. And so basically, over the years, we have relied extensively on HHS surveys such as the CDC surveys, the Youth Risk Behavior Surveillance System, and the BIRFIS, the Behavioral Risk Surveillance System. So we're able to get great data from there. But now, just in the past few years, we've just had an explosion of new opportunities. So to round back to your original question, I think we're at the precipice of an era where we're going to have tons of excellent data on the experiences of LGBT people.
She's piqued my interest. Tell us what some of this data is that's coming forth. Breaking news here at AJPH.
One of the largest surveys that we know is planning to test SOGI measures is the American Community Survey from the census. But when you look at what HHS is doing, we expect we might get better data on older LGBT adults, on Medicaid and Medicare recipients, even on HIV case reporting, Medicaid expenditures, utilization of the marketplace and Medicaid insurance, even TANF and the National Health Nutrition Examination Survey are all some areas where we can expect to see some pretty new data coming out that's SOGI inclusive.
So I would like to highlight some other examples. So SAMHSA has added gender identity measures to the National Survey on Drug Use and Health. The CDC is adding sexual orientation and gender identity to the HIV, STI, and MPOX case reports. CMS is adding SOGI data measures to the enrollment applications for Medicare's Part C and D and to healthcare.gov. And I do want to also recommend and highlight something that is happening with our department is we have finalized a rule with the USCDI, the United States Court Data for Interoperability, which require all electronic health records to be able to collect and transfer SOGI measures by 2026. And that will really be critically important. And you mentioned Healthy People. Healthy People 2030 is in my portfolio at the Office of the Assistant Secretary for Health. And there are many data measures and goals in Healthy People 2030 for the LGBTQI plus community and specifically for the transgender community.
In the summer of 2016, the journal had taken position to defend the SOGI question in the survey for older American adults that was threatened by the administration. And finally, it was kept, and that was a very innovative way of getting this type of information. And Admiral Levine, in January 2017, we published two national surveys, independently assessing the prevalence of transgender individuals in the United States. And I would like to have your opinion today. I mean, then the two surveys quite consistently estimated the number of individuals to about 1 million, maybe a little bit more. What would be your appraisal today of the proportion of transgender individuals in the country?
So I don't have a specific number that I can cite. I think that there have been estimates trying to determine the amount of transgender individuals in the United States. I have heard 0.1%, 0.3%, but we don't really know. And to be honest with you, especially for young people, we live in a non-binary world where many young people identify as queer and as non-binary, and so they're not going to fit into boxes very well. And so it also depends in terms of where transgender individuals, whether they're youth or adults, are in their journey and when they consider to have quote-unquote transition. But again, many of the young people that I see, and I'm interested in Elana's thoughts about this, identify more as non-binary, and they're not going to fit almost any binary category that we as adults try to put them in.
Yeah, I love that you raised that, Admiral. When I started at the Williams Institute, they had just published a report on non-binary people, and what I found fascinating about it was that a huge number of people who identified as non-binary also identified as cisgender. So we had people from categories of cisgender and transgender who identified as non-binary, which kind of blew my mind because I had always kind of lumped transgender and non-binary into one category. And I think that really just shows exactly what you're saying, is that young people particularly are identifying in ways that challenge our older conceptions of what gender and sexual orientation are. And we're seeing such a larger prevalence of people using terms like non-binary and finding they don't identify with the traditional concepts of male or female.
I'm looking right as we speak at an article in the Los Angeles Times from today, which talks about how young people are not going to be quote unquote caged for our happiness. So, and I think that that's great. I think that, I'm a pediatrician, adolescent medicine subspecialist, and I love how youth challenge the norms, and I applaud them for challenging the norms again.
For those of us sitting on these campuses, we've been challenged in the last several weeks. So I think we can appreciate that those challenges actually force us into new innovations. So one of the things I'd like to ask is that, for right now, this all seems very rosy and everything seems great. But maybe you can talk about kind of the worries that you have, because there's the side of all the data that we can get is great. And then there's the other side of data protection and data privacy, particularly for very vulnerable populations, and particularly as states will challenge some of the federal policies. So just a little bit about those worries and the kinds of things you're trying to do in terms of, the protection of data and ways in which vulnerable populations can give it, but at the same time, the federal government is putting bounds around how it can be used against
Well,
it.
so that's exactly right. And our divisions take great pains to protect that incredibly important data for vulnerable populations. And so much of the data as it is released is de-identified. And so CDC and others are taking great pains to protect the identities of vulnerable populations, from challenges they might receive in the states.
May I ask a question here? Can we define vulnerable? Is it the whole population we're talking about, or subgroup? Because Admiral Levine seemed to say they are vulnerable transgender. can we define it just for us, the people are watching us?
Well, I'll start briefly, but when I say vulnerable, I'm usually thinking of groups that face significant health disparities. And we know that the LGBTQI plus community in general faces health disparities. But even within that greater community, there are those that face more health disparities. And the most vulnerable are going to be transgender women of color, who are at risk of not just harassment or discrimination, but they are at risk of violence and murder. And, we acknowledge that during Transgender Day of Remembrance. But there's that intersectionality of health disparities that I think is so critically important.
Yeah, I exactly was thinking along these lines that we look at a concept at the Williams Institute a lot of the time called minority stress. And that concept dealing with types of stress that are unique to people who possess certain characteristics. And in the context of Williams Institute research, that's often looking at whether someone's LGBT or whether they're transgender. What we see is that the stress associated with identity characteristics results in unique forms of mental health and physical health consequences. So we have out there, we have a lot of real threats that can be talked about in the context of legal protections. And there's also the downstream consequences of having those rights be debated or having those laws being put into place and having to live in those states that young people, particularly young trans people right now, have to navigate, as well as the intersectional types of stresses that have to do with structural racism and have to do with disability that would impact someone who is an LGBT person who also possesses those other characteristics. So I think what we're seeing this incredible protection coming from the federal government, but also the states, which are the laboratories of democracy, right, are creating all kinds of new innovations, to use that word, that are requiring a lot of either legal campaigns or requiring policy responses, and also having downstream consequences for our communities.
When we start to talk about vulnerability, one of the things that we know, Alfredo, is from the point of view of mental health, the more that people can be in touch with and recognize those diversity of identities, the more healthy they are. But then what happens is that people often have to live in a community that is really composed of a specific identity. It's a racial ethnic community, and they haven't had experiences with those other identities, or they have, disparate beliefs about those identities. So while we're encouraging people to really be in touch with either their fluidity or those identities, we still have these kind of geographic place things. And so vulnerability will really vary by the community that is significant to you, that you want to be a part of and reside in, the state that or the city that you're in, and the ways in which they interact in their laws, and then the resources, like, do we have Medicaid expansion? Do we have, all these other things that make it okay for the person to be their total self. So, for some of us in health, we start that geographic variable of you can have these identities, but it makes a difference if you're in Texas or Florida or California. It makes a difference as to if you're a Latinx person and you're in a very conservative community. So vulnerability, we're starting to think about this as both our guests have said, in terms of kind of a social vulnerability.
I'd like to highlight that right now in the United States. And so as we think of the social determinants of health, which we're all familiar with, to be honest with you, the legal and political structure of the state that you live in is itself now a social determinant of health. And you can see that in regards to trans youth and their families and their medical providers, and in terms of reproductive rights for women. And the full range of reproductive health services that women need. And so, we have what I like to call our refugees. We have medical refugees in the United States who have to leave their state to get care that they need and deserve in regards to abortion care and in regards to transgender medicine. And I have been around the country, and recently I have been in Texas, in Dallas and Austin. I have been in Nashville, Tennessee. We tried to go to Boise, Idaho, but we got snowed out. I'm going to Jacksonville, Florida. I've been in Kansas City, Missouri, and talked to these young people and their families. And I've gone to children's hospitals and talked to their medical providers. And it's very, very challenging now. And they cannot get the standard of care, medical care for transgender medicine that they need and deserve in those states. And so we have created medical refugees right here in the United States of America.
That is really striking to think of it that way. And we did a study of where young people live, and looked at 4 different types of anti-transgender legislation. 93% of young people in the U.S. live in a state where at least one of those 4 laws was introduced, if not enacted. So 93% of youth live in a state where their rights are being debated in this way. And 25 states have already enacted gender-affirming care bans, and my home state of New Hampshire is likely to enact one as well soon, making that an additional state. So one of the things that we looked at as well was where are the protections? And it seems as though around 50% of trans youth actually live in a state currently where there are shield laws. And what that does is protects access to gender-affirming care or protects people from out of state. But if you step back and look at that, now we have a very divided country where people either have to move to get care, have to seek care across state lines, or have to be denied care in a state where their neighbors can in fact receive it. So it's an extremely difficult situation for those young people.
And that's a health equity issue, because if you are in a family of means, then you can go from Oklahoma or Texas or Louisiana or Mississippi and fly to Boston, or fly to LA or another place, fly to Philadelphia to go to the children's hospital there. But if you don't have the means, then it's a long trip from Louisiana to Philadelphia to get that care. And so it is very, very challenging for those children and families, and it's been very distressing for their medical providers in my field of pediatrics and adolescent medicine.
We insist a lot in the journal that public health should not be only top-down. It should be bottom-up. And this is a tradition of the LGBTQ movement, not paying about us who doubt us. So today, where are those voices? Who should be integrated in the conversation, brought at the table, so that they can also express their own perspective on the policies and what is that?
Well, I think it should be those young people themselves. In adolescent medicine, we love to hear the voices of young people, but also their families who are struggling right with them. And I think that we need to hear from those medical providers, the pediatricians, adolescent medicine specialists, pediatric endocrinologists, who are crying out as well. If you have a child with diabetes, you'll see a pediatric endocrinologist. If you have a child with severe depression, you'll see a child psychologist or psychiatrist. But if you have a child with gender issues, why are we going to the state legislature? We should be going to that same children's hospital, to those very same specialists, the very same specialists that are treating children with other conditions. And so I do want to highlight the voice of the American Academy of Pediatrics, the Society for Adolescent Health and Medicine, the AMA, which have spoken out about this issue.
And I would add, on a federal policy level, I would say one of the hallmarks of Admiral Levine's term with HHS is also engaging with LGBTQ community members about these issues and really having those direct conversations where feedback is going both ways, and where we can really understand the policies that are happening, and also where the policymakers are really hearing from community members.
I was just going to comment that this issue of leadership matters, because Admiral Levine, when you were mentioning the AMA, well, we know Jesse's there.
That's exactly right.
It has spoken out. We have you. And look at the change that has come to HHS. So we also need to remember that's an important, there are voices to be had, but there's leadership to bring to bear on many of these issues. So since we're getting kind of near the end, I'm going to ask a question, and then Alfredo, please, any comments, and have you as well. We've had a lot of good news. This is one of those exciting podcasts because there's more good news than bad news. So what are the next 2 or 3 issues that you think we should really be kind of leaning into to try and accomplish in the area of increasing transgendered either health, mental health, or data collection, so that we kind of have a sense of where should we all be trying to push forward in order to accomplish, and kind of over the goalpost, those next few things that you'd each like to see.
Well, first, I think are these challenging state laws. It's not just laws challenging gender-affirming care for young people, but also the quote-unquote don't say gay bills, the bathroom bills. So many regressive actions by states which are targeting, again, the vulnerable youth and adults that I think are impacting mental health. And so that brings me to the second, which is mental health challenges that youth and adults in the transgender community are having. And we need to make sure that they all have access to the mental health care that they need and deserve. And the third I want to highlight is the syndemic of HIV, hepatitis, and now syphilis. So syphilis has become a significant sexually transmitted infection of concern in the United States. And we actually have a syphilis syndemic task force at HHS, which I lead, looking at all the different factors that have led to increases in syphilis in a number of communities, particularly the Black African American community, the American Indian Alaska Native community, but the gay and bisexual men and other men who have sex with men and other transgender individuals who have sex with men communities. And so we are looking at expanding testing, expanding treatment, and expanding data. And I guess the final thing is, I was in my residency program in 1983 at Mount Sinai Hospital and saw HIV/AIDS at the very beginning. And I was there at the beginning, and I want to be there at the end of the HIV epidemic in the United States.
Great. Elana.
Something I've been thinking about lately is this relatively well understood, well-known framework of contact theory. The idea that if you meet people that are different than you, then that can help reduce prejudice. And one of the researchers at the Williams Institute has been looking at public opinion on trans rights. And generally, people support trans rights and support protections for trans people. But when you get into some of the stickier issues, which we've seen have been really effectively leveraged as wedge issues to create division, people have different types of opinions. But we've also seen that when people know someone who's transgender and interact with trans people in a more direct level, then that does reduce that level of prejudice and may make them less likely to vote in favor of a gender-affirming care ban or vote for a bathroom ban. So one area I'd like to see more is around that. How do we foster better interactions? How do we increase, maybe 1/3 to half of non-trans people know a trans person? So how do we get that to 100%? And then I'd be remiss if I didn't say research. There's so many opportunities for good research here, particularly with all the excellent new data that's going to be coming out. But also, I believe that NIH is thinking about its strategic plan for the next 5 years for sexual and gender minority research. So where are the opportunities there? It's an open RFI, I think. So I'm looking forward to us commenting, and I know others have a lot of thoughts about where we can see research going in the near future.
And Elana, what I can say is that the opportunity to publish this good data that's coming, that's AJPH. I want just to remind you that in the summer of 2001, we had the first full issue of a journal ever entirely dedicated to LGBTQ health, that we've been trying to follow all the science on this, whether it is health monitoring, whether it is public health issues in the whole community, the end of the HIV epidemic. And I really hope that you'll send us your work. As Vickie had, the first time I met Vickie a few years ago, she told me, and don't forget, I was just a research editor, and don't forget, AJPH is a major venue for LGBTQ health. And I said, yes, I will. I know that, and I'll try to do my best. Thank you very much for your time, Admiral Levine, and for all the great work. Elana Redfield, also thank you for being there and your great comments. And of course, Vickie, my good friend and colleague Vickie, thank you. It's always a pleasure to organize podcasts with you. So here we got to the end of this podcast. Thank you and bye-bye. Hope to see you in person soon.
Bye, thank you.
Thank you very much.